Okay, this is we're going to talk about the endocrine system for week 4. And under this category, we're going to talk about the complicated ones, which is DKA, known as diabetic ketoacidosis. We're going to cover HHS, which is your hyperosmolar hyperglycemic syndrome, uh, diabetes insipidus, also known as DI, and syndrome of inappropriate anti-diuretic hormone, which is also known as SIADH. I'm going to go ahead and do a little overview on diabetes before I further discuss these other diseases, only because I know it's been a while since you guys had med-surg, so I think going over a little bit of just an overview of diabetes will help out understand these complicated diseases. Diabetes kills more people each year. When you compare it to breast cancer and HIV combined, it is the 7th leading cause of death in the U.S. And over about 300 death certificates are listed as diabetic complications. There's complications will involve either an infection or sometimes another thing that occurs with these patients is they'll have end-stage renal disease. A lot of times it will be a complication of their diabetes. And if we think about a lot of the complications that these people will have, they'll also have neuropathy. They'll have problems with their eyes. So diabetes, if it's not well controlled, can really be a pretty detrimental disease. And especially now we're having a growth of more diabetic children. A lot of it is we have a lot of childhood obesity now, and I know you guys did pediatrics already, but you must have discussed how we're having now a wide range of now kids that are having hypertension, and they're also having diabetes, and a lot of it is related to the obesity rates that we have. We do have a lot of type 1 diabetics, which is, you remember, with type 1 diabetes, it's usually your young people. There's about 29.1 million children and adults together with type 2, and then when we break it down to type 1, we have about 1.2 million. There's a lot of people out there that are currently undiagnosed. They're having all these symptoms, but they're justifying it, thinking that it's something else, so they're not aware that they have this disease. So that's about 8.1 million, which is a big number. Now let's do a quick snapshot on glucose metabolism. If we talk about glucose metabolism, one of the things we want to know is that, first of all, it represents a very complex physiological process that glucose is utilized by the body. We know that our body needs glucose metabolism, and there's other things that influence it. There's like multiple variables that are involved when it comes to glucose metabolism. And when we get down to the cellular level, we know that our body needs this glucose for energy, and we know with this energy we are able to produce ATP synthesis. And without ATP, that's our energy. So without it, we are unable to really function effectively. If you think about many times how many of you have been perhaps hungry and you get very sluggish, that's because our brain functions with glucose, and it's unable to produce that ATP because we have low glucose levels because we haven't ate. Then we have the beta cells. The beta cells, if you can think back a little bit about your pathophys, is located in the island of the Langerhans in the pancreas. These secrete the hormone insulin, which facilitates the movement of glucose across the cell. We know that without insulin, our glucose cannot enter into the cell. I always say that insulin is the car of glucose that travels directly into the cell. Without the car, it can't go anywhere, so it's at a standstill. Insulin prevents excessive breakdown of glycogen as well in the liver and in the muscle. It facilitates the formation of lipids when it's inhibiting the breakdown of stored fats. It also assists in moving amino acids into cells for protein synthesis. Insulin is necessary for optimizing normal carbohydrates metabolism as well, along with glucose utilization. When we eat, immediately our insulin levels begin to rise within minutes. It can rise immediately, and it peaks usually within 30 to 60 minutes. And for not us that are non-diabetics, we return back to baseline within 2 to 3 hours. Then we have diabetes mellitus, also known as diabetes, or sometimes we hear it called DM. We know that this is a disorder of someone that's constantly hyperglycemic. It can be caused by two different things. Either you have a pancreas that does not produce any insulin at all, which is your type 1s, or you have a pancreas that produces very little insulin, not enough, and that would be your type 2. Sometimes we can say that it's a destruction of the alpha and beta cells of the pancreas, which is what prevents it from making this insulin. There is a huge dependency on insulin to prevent ketoacidosis, and of course we need it to maintain life. Several types of diabetes you should have reviewed. There is type 1, type 2, and gestational diabetes 2, and if you recall for OB, that would be your gestational diabetics. Then we have the cells. These cells produce the hormone called glucagon. This one stimulates the breakdown of glucagon in the liver. I have a hard time pronouncing that. The formation of glucagon. This one is decreased glucose oxidation, and it increases blood glucose levels. If you remember, we have two. It further breaks down to two. We have glycogenolysis, and then we have glyconeogenesis. Glycogenolysis is the breakdown of glycogen to increase blood glucose concentrations to their optimal level, and then glyconeogenesis is the formation of glucose from fats and proteins. Glucagon prevents blood glucose from going low. That's our protective mechanism that we have to prevent severe hypoglycemia, and also works. It helps decrease certain levels below when the body is fasting or when we are between meals. Our body will make glucagon as a protective mechanism. Then we have the delta cells. Delta cells produce this hormone called somatostatin. And somatostatin is like a neurotransmitter that inhibits the production of glucagon and insulin. Then we have normal serum glucose levels. It varies depending on which book you look at, but in general, you're safe to say 70 to 110. If someone is within 70 to 110, that is what we call euglycemia. And if you think about that term, you break it apart, that just basically is saying normal levels of blood glucose. Then we have hyperglycemia. That is a term that is used to describe elevated blood glucose levels. Anything greater than 126 in the fasting state is considered hyperglycemia. Anything greater than 200 with an oral glucose tolerance test is considered hyperglycemia. Then, of course, we're going to talk about ketoacidosis. This is an extreme increase in the hyperglycemic state. This is a metabolism of fats that results in fatty acid production, which results in the conversion of ketone bodies. This increase in ketone bodies can lead to metabolic acidosis, and this is a complication of type 1 diabetes. We're going to talk about this. And we're also going to talk about hypoglycemia. And we talk about hypoglycemia, although you've talked about it before, but I talk about it again because with all the treatment interventions that we do for the diseases that we're going to talk about, our patients are at high risk of hypoglycemia. And that's defined as any blood glucose less than 70. Some of the common labs and procedure tests that we do are listed here. We have the random blood glucose test. And what this can be drawn any time of the day. That's as you guys are doing your clinical rotations, you go in, you draw your patient. Should be tested before they eat their lunch or their dinner. That's your random blood glucose test. We know that certain medications that we give our patients can increase our blood glucose levels. Stress increases our blood glucose levels, which is why in the critical care setting we know that every single patient that is fighting for their life is in a stressful event. So many patients in the critical care setting will have their blood glucose checks even though they're not diabetics. Many times I'll have patients ask me, why am I testing their family member? And I'll let them know it's because possibly we could have started them on steroids as well. And if you remember, steroids also elevates your blood glucose. But I'll let them know that we're testing their blood glucose levels because number one, their body is in stress, and number two, we have started them on a medication that can possibly increase their blood glucose levels. Then we have the fasting blood glucose test. This one is the patient has to have been without any food for at least 8 hours prior to the test, and anything greater than 126 would be considered hyperglycemic. Patients should fall within 70 to 110 in this category. Then we have the postprandial glucose test. What this is a serum glucose test. It's measured 2 hours following a meal. So what this does, it's reflecting the efficiency of how insulin is mediated in order to doing glucose uptake by the peripheral tissues. Normal glucose levels should return back to fasting levels within 2 hours. That was kind of like going back in the first slide where I talked about that. We have oral glucose tolerance test, and these are also the tests that some of the women do in a certain, I forgot what trimester in pregnancy, but they'll do that to make sure they're not gestational diabetics. And what this is, it's a fasting blood glucose that is drawn in the beginning of the test, and then people have to drink this awful drink that's plain thick like syrup glucose. Then they'll draw serum levels of the glucose are drawn every 30 minutes and for at least 2 hours, and that's just to monitor for we have to monitor for hypoglycemia throughout the procedure. Then we have the very famous hemoglobin A1C, and hopefully most of you remember what that is. But what this is how we are going to evaluate our treatment interventions. And I'll break it down to a little bit of patho. Glucose normally attaches to the hemoglobin molecule or on the red blood cell. Hemoglobin is a part of the red blood cell that carries oxygen into the cells and sometimes joins the glucose in the bloodstream. As a result of this, the higher the blood glucose levels, the higher the levels of glycosylated hemoglobin, which is your HbA1c. This value is an average blood glucose level measured over the previous 3 months. That's why it's very good at letting us know what are the treatment, if our treatment interventions are working. Sometimes some doctors will check just to check compliance to see if the patient is compliant or not. But when you see these in exam type of questions, it's usually for us to see if our treatment interventions are working. It's usually recorded as a percentage, and non-diabetics run from anywhere from 4 to 6%. If a diabetic is in good control, should be less than 6.5. Sometimes some will just say less than 7, but poor control would be anything greater than 7%. This here is something that can help you remember just general terms of someone who is diabetic or glucose metabolism. This is because not quite an acronym, but yeah, I guess you can say it's an acronym, and I call it LIFE. L starts for loss of fluids, which our hyperglycemic patients will have an increased osmotic gradient. So we know that water is going to move out of the cells and into the circulating volume to decrease this osmolality. And due to this, there's going to be an increase in circulating volume of water that is not being reabsorbed by the renal tubules. So what's going to happen is the patient's going to have polyuria, which is an increase in urine output. Secondary, as a result of this polyuria, there's going to be loss of fluids that are going to result in dehydration. This dehydration is going to now trigger the thirst mechanism, which is going to assist in compensating for this losses of fluid. So the outcome of that will be polydipsia. We're talking about now the 3 P's, if you guys remember discussing this a few terms back. The I stands for infection or integumentary. We know that there's an impaired immune function due to this alteration in the immune system. The response that results in an impairment of white cells for phagocytosis. There's persistent glycosuria that predisposes the patient to urinary tract infections. We know that our diabetics have delayed wound healing. And as far as the skin, there's something called a lipodystrophy. That's like hypertrophy of subcutaneous tissue. And that usually happens when they're using the same injection sites repeatedly. Then the tissue becomes like hardened and reddened. I don't know if you've ever seen this in your patients. It looks like an orange peel appearance. So that's the A for life. And then F will be food. We know that these patients are very malnourished. They come in looking very thin. We call that polyphagia, which is tissue breakdown and wasting results in hunger. They have weight loss. They have a lot of fatigue, and that can also be due because of the weight loss due to muscle wasting. Then we have the E for electrolyte and acidosis, and this is primarily what we're going to focus on today because these are the complications. You guys already discussed the standard disease process in your previous terms, so I just wanted to give you a good overview, but now I'm going to start gearing into the disease processes that we're going to talk about today. So with the E, I said it's electrolyte slash acidosis. We can break it down to metabolic acidosis with ketoacidosis. This one is the more serious of the two because of the ketones and the metabolic acidosis state that our body goes through. So what happens with this one is that there's an increase in mobilization of fat and protein as energy when this glucose is not available. That's your ketones. Then you have fat metabolism, which is going to cause breakdown of products called ketones. Ketones then accumulates in our blood and is excreted through the kidneys and lungs. This is why your patient has a Kuzma respiration, because it needs to be excreted. And that's why your patient comes in once it's excreted through the kidneys, and they have this very thick-like urine. Ketones interfere with the body's acid-base balance because what it does is produces hydrogen ions. The pH then decreases and metabolic acidosis develops. Our body, because it was made so wonderful and is able to compensate for things, it has a compensation mechanism. This is when our respiratory system is going to increase in rate and depth. That is your Kuzma respiration, because now it's trying to blow out this excess CO2. And they, I don't know if you've heard about this fruity breath, they get like an acetone type of breath. Then we have loss of electrolytes or imbalance. That's number 2. We have hyperkalemia, which because of loss of the electrolytes. Same mechanism again with your hydrogen ions. So what happens is, as the pH of the blood decreases, This now is becoming acidosis because there is an accumulation of hydrogen ions that moves from the extracellular fluid to the intracellular fluid. Our cell at that point dumps out the potassium because it needs to make room for this hydrogen, so it kicks out the potassium into the bloodstream. Now that is what's causing hyperkalemia. And when we talked about dysrhythmias because of hyperkalemia, if someone's potassium gets sometimes usually greater than 7, you start seeing these tall peak T waves and a wide now QRS. It can be very dangerous and it can be lethal. And most of these patients have to end up having emergency dialysis, or we do other interventions that I'll talk about later in our lesson here. Okay, now we're going to start going into the complications of what you need to know for this lesson. So, diabetic ketoacidosis is one of the serious complications that diabetics can get. And this is usually because we have all these acids in our body that are called ketones. This condition, it develops because our body cannot produce enough insulin. Insulin, as I talked about, plays a very important role in helping our glucose go into the cell and give energy for our muscles and our tissues. Without enough insulin, our body begins to break down fat as fuel, and that fat creates a buildup of acids that is in our bloodstream and is called the ketones, which eventually ends up leading to diabetic ketoacidosis if it's left untreated. So, a quick overview. This is what the patient that comes in with diabetic ketoacidosis is going to look like. I did say that it is a life-threatening crisis that happens to our type 1s, usually caused by infections. UTI is one of the more common ones. They can get it from any viral or bacterial infections. So when you think about DKA, it affects our type 1 diabetics, and it can be any blood glucose that is going to be greater than 250. Some of them come in much higher than that, but we base it on acidity levels and we base it on bicarb levels as well. So pH tends to be less than 7.3, and they're in an acidotic state, and our bicarb levels are going to be less than 15. And like I said, infection tends to be one of the main reasons why our type 1 diabetics will go into ketoacidosis. This little diagram here is just showing you the definition and an overall view of what you're going to see. The patient is going to be hyperglycemic, blood glucose greater than 250. They're going to be in an acidotic state, and they're going to have ketones, and the ketones are going to be present in the urine and in the blood. And it's caused, like I mentioned earlier, by profound deficiency of insulin. The patient will have hyperglycemia. They're going to have ketosis, acidosis, and dehydration. These patients come in extremely dry, and once in a great while you may see people with type 2 have this, but it's very, very rare. So it's always your type 1, and it's usually because I mentioned they have some kind of infection, or there can also be stress because the pancreas cannot meet the demands of the insulin. That would be if for some reason you have a type 2 that gets it. So I'll say that again. Primarily it occurs with people with type 1 diabetes, but that rare occasion that you may see a type 2, it's usually because there's a profound amount of stress and the pancreas just cannot meet these demands of insulin. This can develop as in less than 24 hours. If these patients come in on time, mortality rate is less than 1% with good, adequate management. I talked about illness, infection, inadequate insulin dosages, poor self-management, neglect can be sometimes a reason. Uh, we know that sugar is a main source of energy for our cells that make up your muscles and other tissues, and insulin needs to be present in order for sugar to be enter the cells. And without enough insulin, our body just cannot use sugar properly. So it's kind of like hanging around in the bloodstream with nothing or nowhere to go. When this happens, there's a release of hormones that go into our bloodstream. These are going to break down fat as fuel, and that is what makes your ketones. So excess ketone buildup in the blood will eventually spill over into the urine, and that's why these patients will come in and we do urine test and we'll find ketones in it. So illness, what happens with the illness or infection is that our body will go into a hypermetabolic state, and because of that, your body will produce higher levels of certain hormones like cortisol and adrenaline. Unfortunately, these hormones counter the effect of insulin, so sometimes this is what triggers an episode of diabetic ketoacidosis, or a problem with insulin therapy, missed insulin treatments, or inadequate insulin therapy. There's either too little insulin in the system, and other triggers can be emotional trauma, heart attack, alcohol or drug abuse, usually cocaine, and meds such as corticosteroids or sometimes diuretics. Okay, everything I just said was for that particular slide. Okay, going on to the next slide. Okay, this is just a little diagram showing you a little bit of the pathophysiology that happens with DKA. So when we have a circulating supply of insulin is insufficient or not sufficient, glucose cannot be properly used for energy. The body compensates by breaking down fats that are stored normally. It's not what our body wants to use, but it has no choice because there's nothing else to use. So it's going to start breaking down these fat stores as a source of fuel. And the byproduct of that is those ketones. And remember, ketones are acidic byproducts of fat metabolism. It can cause serious problems when they become excessive in the blood, because these ketones or ketosis is going to alter the pH balance, which is going to cause metabolic acidosis to develop. Ketonuria is a process that occurs when these ketone bodies are excreted in the urine. During this process, electrolytes become very depleted, as cations are eliminated along with anionic ketones in an attempt to maintain electrical. It wants to stay neutral. Insulin deficiency impairs protein synthesis, and it causes excessive protein degradation. And with this results in nitrogen losses from the tissue. Insulin deficiency also stimulates the production of glucose from amino acids, and this is all coming from proteins, and this is in the liver and leads to further hyperglycemia. Because there's a deficiency of insulin, the additional glucose cannot be used, and the blood glucose level rises, further adding to osmotic diuresis. If this is not treated, the patient will develop severe depletion of sodium, potassium chloride, mag, and phos. That's why when these patients come in, we have many times we'll draw their blood levels as much as every 4 hours, anywhere from every 4 to 6 hours. they need vigilant monitoring of their electrolytes and their blood glucose. Many of them will come in very nauseated. They will do a lot of vomiting, and this vomiting caused by the acidosis results in even more fluid and electrolyte losses. Eventually, hypovolemia can lead them into shock, and it would be hypovolemic shock. Renal failure may kick in as well because there's not enough volume for perfusion, and along with the retention of ketones and glucose and the acidosis, all comes into effect. If the patient is left untreated, they will become comatose secondary to dehydration, and they'll have that severe electrolyte imbalance and acidosis. If this patient does not come into the hospital, he or she will die. This diagram here is just breaking it apart, kind of like giving you an idea of what happens. So we have unchecked glyconeogenesis, which leads to hyperglycemia, any blood glucose greater than 250. Then we have the osmotic diuresis, which is going to cause a dehydration, and I explained that a few slides back. Then you have the unchecked ketogenesis, which is going to create these ketones. And then we have the dissociation of ketone bodies into hydrogen ions. I talked about the anions. Then it's going to cause an anion gap metabolic acidosis. So your patient's going to come in. They're going to be complaining of abdominal pain, nausea, vomiting. As they have this abdominal pain, many times it's because they've been vomiting, and they'll come in with that Kussmaul's respiration, which is rapid, deep. It's associated with dyspnea, and all of this is the body's attempt to reverse this metabolic acidosis through the exhalation of excess CO2. Acetone is that sweet, fruity odor that will come out of their breath, and we're going to do the lab findings. We're going to find that their blood glucose level is greater than 250. We're going to do an ABG. We're going to see that their arterial blood pH is less than 7.30, and their serum bicarb level is usually less than 16, and moderate to high ketone levels in the urine and in the serum. These are all the T's, the P's, and the H's. The T's, we know that the patient is going to come into Kipnik. They're going to have tachycardia because they've lost all that fluid, tachypnea because they want to blow out that CO2. Then they're going to have that polyuria because that's your 3 P's. They want to, they're having a lot of excess urination. Then you have the polydipsia. They're very thirsty. And then you have the polyphagia. These are starving cells, is what I call them. And then you have the H's because you're going to have hyperglycemia. Remember, the patient can have orthostatic hypotension or hypotension in general from the low volumes of fluid. They're going to have hyperemesis because that abdominal pain, that nausea, that vomiting, that shift in hydrogen ions. They're going to have hyperthermia. Many of them will come in very warm, and then they're going to have hyperventilation because they're going to be trying to blow out that CO2, aka Kussmaul's respiration. Their mentation, remember, they're going to be lethargic, and they're going to have sunken eyes. Their skin is going to be hot and dry, and they're going to have that acetone breath. There may be times when someone may have DKA. If it's found very early, they can actually be treated on an outpatient basis. But it's very rare that they do come. Usually, by the time these patients come into the hospital, they come in with all the signs and symptoms of already a later form of DKA. But if someone is good about doing self-monitoring of blood glucose, uh, they'll be able to find this. They'll see changes in their, or if there's people out there that are diabetics and they know their bodies very well, that they're able to catch any changes in their signs and symptoms of their diabetes. But when they come in with that severeness of the acidotic state, these patients are going to be required to be hospitalized. These patients are going to be hospitalized in a critical care setting because you're going to need very close monitoring, very vigilant monitoring. We are going to have to check their blood glucose every hour. We're going to have to be checking their electrolytes. Depending on what the physician has ordered, can vary anywhere to 4 to 6 hours. There's going to be a lot of electrolyte imbalances that we're going to have to be replacing. A lot of fluid volume that is going to have to be given to the patient. Um, if someone does not have the severe vomiting and abdominal pain or the severe electrolyte imbalances, like I said, they can very safely be monitored at home, but it's just less severe forms of DKA. They'll be managed outpatient. Other things that they can consider is as far as where the patient is going to be managed. If do they have a fever? If they have a fever, then more likely they're going to have to be in the hospital because we might be dealing with an infection, which is what kicked him into DKA. How about their mental status? Got to check into that. Are they lethargic? Are they awake? Uh, we want to find out what caused their ketoacidosis. And any patient with DKA who has an illness such as pneumonia or UTI, these patients are going to be the ones that we're going to admit into the hospital because we do want to treat their infection. Now, as far as nursing management goes, we know that DKA is a serious condition and it can get bad very quickly. So we need to treat these patients promptly and efficiently. We want to make sure that these patients have a pain airway, and we have to administer oxygen via nasal cannula or non-rebreather mask. Because they have fluid imbalances that can be life-threatening, the initial goal is to establish IV access. We need to give them a lot of fluid. We want to begin a fluid usually when we initially begin. We're going to give 0.9. It's usually NS. I do have half, but it's usually NS is what we're going to give. And we want to start restoring urine output as well. We're going to keep a very close eye on that. We want to make sure that they're having anywhere from 30 to 60 cc's. We want to make sure that we raise their blood pressure, so we want to give them fluids. When blood glucose levels approach anywhere around 250, we need to include now a 5 to 10% dextrose is added to our fluid regimen. And the reason why we do that is because we want to make sure that we prevent a sudden drop in glucose. Our body hates to be flip-flopped. It does not like that. So that's why we want to make sure that as soon as our blood glucose levels go down to 250, we are going to add that 5 to 10% dextrose, and that's going to be on some form of protocols. Most hospitals have protocols when they treat these diseases. Another thing we're going to be careful about is as well as a sudden drop in glucose, this can be associated with cerebral edema, so we need to be careful. Overzealous rehydration, especially with hypotonic IV solutions, can result in cerebral edema, so we need to be very careful. Patients that are cardiac or renal patients, we gotta watch them for any kind of fluid overload. Auscultate those lungs, look at their JVD. We want to monitor the potassium levels before we start insulin. If the patient is hypokalemic, insulin administration will decrease the potassium levels, making early potassium replacement is essential. Although initially serum potassium levels can actually be on the higher end, levels will start decreasing on their own without us having to do any additional interventions once we begin insulin. And I hope you thinking, why is that? Well, because we're giving insulin now, we know that this hydrogen ion kicked the insulin out of the cell, but now that there's more insulin on board, now this potassium is going to start driving itself back into the cell. So we don't want to go from high to all of a sudden um, a big drop. That's why when these patients come in with an elevated potassium, we are not aggressive to treat their hyperkalemia, unless, of course, it's in a lethal range. But when they're just, some hyperkalemia, we're not going to do any intervention because we know that as soon as we start the insulin, this potassium is going to make its way back into the cell on its own. We do start IV insulin administration because we need to start correcting this hypoglycemia. And we, depending on which insulin protocol is used, it can be anywhere from zero point 0.1 unit per kilo per hour. By continuous infusion, we do start an insulin drip on these patients. Insulin drips could only be given in a critical care setting. It's important to prevent rapid drops in serum glucose because we want to avoid cerebral edema. A blood glucose reduction from anywhere from 36 to 54 milligrams per DL per hour will avoid complications. And we know that insulin allows water and potassium to enter the cell along with glucose and can lead to depletion of vascular volume, and that you actually may start seeing a little bit of hypokalemia. That's why I mentioned earlier that we make sure that our patients are their electrolytes are going to be very closely monitored. Okay, so as these patients come in, we're going to do a history and a physical on them. We want to ask them questions about if they've been thirsty, have they had polyuria. We want to start finding out some things about these patients. Are they having any kind of abdominal pain? How about any weakness? And as we're doing our exam, we're going to be observing for things such as Kussmaul respiration, any kind of tachycardia, any kind of orthostatic blood pressure changes. We're going to look inside their mouths, look for mucous membranes. We're going to do skin turgor checks. And remember, the best place to do a skin turgor check is in the chest area. When we draw labs on these patients, these are some of the things that we're going to find. They're going to have an increased blood and urine and ketones. So we'll notice that in serum and urine. We're going to see severe hyperglycemia. They're going to have a low bicarb level. They're going to have a high ion gap. We'll talk about an ion gap in a few slides from now. They're going to have a low arterial pH and a low PCO2, which is they're going to start showing their compensation, which will be their respiratory. They're going to have those Kussmaul respiration. Okay, now I'm going to talk about the ion gap when it comes down to metabolic acidosis. The ion gap plays a very important role when a patient is kept in the critical care and when the patient is transferred out of the critical care. Is all based on this anion gap. And what an anion gap is the difference between your positively charged ions and your negatively charged ions, along with serum, which is your electrolytes, plasma, and urine. So in the critical care setting, we do this calculation. And this calculation gives us what our anion gap is. You will many times in the critical care setting, what we say is the patient still has uh, the anion gap. We talk about, has the anion gap closed or is the anion gap still open? The normal anion gap should be less than 12. So what we do is remember, we're checking our electrolytes constantly. So we are actually checking this anion gap, making sure that it closes. Because once this anion gap closes, that means that our patient now, although they may still have hyperglycemia, but the metabolic acidosis state now has began to normalize. So what you want to do is we get the sodium level, we get the chloride and the bicarb, we add the chloride and the bicarb together and we subtract the sodium. And based on what that value gives us, that's going to give us our anion gap for the patient. Causes of anion gap acidosis is the ketones, the ketoacidosis, which is diabetic alcoholic. Then we have lactic acidosis. We have uremia, which is your phosphates and your sulfates. Then you have poisonings and overdoses can also cause an anion gap. In our case, we're looking at ketoacidosis. And in ketoacidosis, the delta of the anion gap is above 12. And this is when it will validate that a patient is in true metabolic acidotic state, and they need to be admitted into the critical care setting so we can regulate all of their electrolytes along with their hyperglycemia state. Potassium is another electrolyte that we monitor very closely in our patients with DKA. Potassium, as we know, is an intracellular electrolyte, and with DKA it's high because we find it flowing in the extracellular environment, and that we said is caused because the hydrogen ions kick it out of the cell. Urinary losses occur during the evolution of DKA. That's usually due to glycosuria. Total body potassium, these stores are greatly reduced in any patient with DKA. So this potassium is reduced in the intracellular, but it is high in the extracellular. We know that potassium moves from inside and it's out in our plasma. Our levels, meaning it's in our bloodstream, it's hanging out there. Because this insulin deficiency is unable to take it back into the cell. As we start giving insulin replacement to this patient, as mentioned before, now this potassium is going to start making its way inside the cell. So usually the potassium prior to treatment is high, but it may drop during therapy because now all of this potassium that was hanging out outside of the cell now is all going to be transported back into the cell. These are some of the initial lab findings that we'll see. We will do a very comprehensive metabolic profile because we know that their electrolyte imbalances are going to be completely out of control. We're going to check serum osmolality, so we're going to do blood tests, and we're going to check ketones in the urine and in the blood. We're going to do arterial blood gases because we need to know our bicarb levels and our CO2 levels, and we will also determine the acidotic state of our patients, which we know most DKA patients will be in diabetic ketoacidosis. We would check lactate levels because remember, a lot of these patients will go into DKA because they have some form of infection, so we want to make sure that they are not they don't have any septicemia. We want to do a CBC panel, check their hemoglobins. We'll do your analysis, ECG, and I'm hoping that you're thinking that we're doing an ECG because we're worried about our potassium levels. So we want to make sure that they're not having any dysrhythmias, because remember, initially they're going to have hyperkalemia and blood cultures. We're going to do those because same thing, we're suspecting infection, so we want to see what kind of microorganism we're dealing with. Here is just another formula. This is a nice to know, not a need to know. I don't want you to overly stress over this, but it's just showing you how some of the formulas that we use to determine serum osmolality and effective osmolality. Now we're going to start talking about some of the treatments and the recommendations we do for DKA. The very first treatment that we want to do is we want to start treating this severe hypovolemia. We want to start giving them a lot of fluid. We will give these patients many liters of fluid to try to hemodilute them. Number one, because remember, they're coming in with a very high glucose level. We also want to replace their losses because they're going to come in very dry. Remember, they're going to have a dry mucous membranes, poor skin turgor, low urine output, hypotension. We need to replace all these losses by giving them liters and liters of normal saline. After initial volume resuscitation, so remember, our very first goal is going to be to do a volume resuscitation. After our initial volume resuscitation, or for more mild dehydration, we're going to use our IV fluids are going to be anywhere from 250 to 500 cc's per hour. It seems like a lot, but when you think about these patients, when they come in so severely dehydrated, this is barely enough to normalize their body fluids in their body. For every 100 milligrams of over DL blood glucose elevation, we're going to add 1.6 milliequivalents to our sodium value. Once we start correcting our electrolytes, we're going to do changes in fluid. We might even use half normal saline, just depends on whatever the doctor orders. When the blood glucose reaches about 200 or even from 300, we're going to go ahead and change to 5% dextrose or half an S normal saline. Just depends, whatever the doctor has ordered. And the reason why we do that, because we don't want our patient to go into severe hypoglycemic states. 150 to 250 per hour, and we're going to be checking our blood glucose every hour. If our patient goes into a hypoglycemic state, we're going to check much sooner than that. We want to make sure that our gap is closed, and our gap is considered closed when our 9 gap is less than 12. We're going to start these patients on insulin sliding scales, and every hospital has their own type of sliding scale that they use. As there's sliding scales out there that are used for just a hyperglycemic state, and then we have insulin sliding scales that are used specifically for DKA. So our goal is to initially correct our hypovolemic shock with fluids. Remember, we're going to give many liters and liters of fluid. After we do that, we're going to correct hypokalemia if present before starting insulin. The reason why we want to correct a hypokalemia if this patient comes in hypokalemic, remember, every patient is going to be unique. However, on average, they come in hyperkalemic, but our patient is never but perfect. So if for some reason they come in and they have hypokalemia. This you will actually generally see in your HHS, but if they do, you want to make sure that you always correct your potassium before you start the insulin, because if they're already showing hypokalemia, what's going to happen when you start the insulin? The potassium is now going to be carried back into the cell, which is further going to cause more hypokalemia. When we start insulin, we will start based on units per kilo per hour. It's going to be on a very strict sliding scale, and depending on what the value is, that's how much insulin we're going to use based on a scale. If plasma glucose does not decrease by 50 to 75 in the first hour, we're going to be titrating this. So we titrate our insulin based on our random blood glucose checks that we do. Remember, we're going to be checking this every hour. The patient has to remain on an insulin drip until the anion gap closes. Once this anion gap closes, physicians will switch over into a subcutaneous insulin, and many of them will also give a long acting, so they'll go ahead and initiate an NPH type of insulin. The rationale for our insulin protocol for DKA and HHS. Even with low dose insulin therapy, hypokalemia and hypoglycemia may continue to occur. That's why, like I said before, we want to make sure that we're keeping a very close eye on these levels. Failure to reduce insulin infusion rate as the blood glucose approaches the target may lead to hypoglycemia. So just as much as we like having to decrease, remember I talked earlier in the beginning that we also need to talk about hypoglycemia, because our insulin protocols can cause our patients to go into hypoglycemia. There is a lag between the change in the IV fluid rate and the resulting effects. So we want to make sure that we truly are keeping a very close eye on these patients, and that we're going to make sure we prevent them from going into hypoglycemia, because hypoglycemia can be pretty detrimental to them. They can become very lethargic, and they can become diaphoretic, and we're going to talk a little bit more about hypoglycemic in a few slides. This is an insulin protocol for DKA. So what we do is we're going to check our blood glucose levels, and based on where they fall, you're going to go into your columns, and you're going to go ahead, and that's how you're going to titrate your insulin. Because let's say that your patient's blood glucose is 150 and you are currently on column 3 and your insulin is at 1.5 units per hour, and with this one it's going to let you know either if you need to move to column 4 or if you need to decrease, and all of this is based on your results on your column. That tells you what your blood glucose level was. It sounds very confusing. This is good to know, but you don't need to know. And the reason why I'm not putting a huge emphasis on this is because everywhere you work, they're going to have their own insulin protocol. So I don't want you to stress out over this, okay? Just nice to know, because you can get an idea on some of these insulin protocols that we use in the hospital. Here it's just giving you a little bit of what the physicians will order for their patients, and it gives you guidelines and standing orders on what to do based on what's going on with the patient. Potassium repletion and DKA. I actually should move that slide because I already talked about potassium. But we know that life-threatening hypokalemia can develop during insulin treatments because now our potassium that is in the extracellular environment is going to go into the intracellular inside the cell. Potassium re-enters cells with insulinization and correction of acidosis, and the small extracellular compartment experiences a huge drop in potassium concentration. And we want to make sure that it's replaced during the treatment of DKA, and it's almost required. So many times, like I said, initially they're going to come in with may come in with hyperkalemia. Once we start giving them all those boluses of fluid, since we start hemodiluting the blood, we start hemodiluting the hyperglycemia, then we're going to go ahead and check our potassium, replace if we have to replace, and then we're going to start our insulin. And this slide here is just giving you an outline of what we do as far as the replacement of potassium and DKA. If the potassium is greater than 5.2, then of course we're not going to give potassium because we know that it's going to start dropping on its own. If the potassium is greater than 3.3, we're going to hold the insulin, and then we're going to go ahead and give the replacement of potassium. And then so forth if you look at the next one, what we end up doing based on what's going on with the potassium. Phosphorus depletion. With this one, it's just talking about, because remember, the patient has all their electrolytes at normal, we're going to have a sharp drop in serum phosphorus can occur. So we want to make sure that as we're doing electrolyte checks, we're also checking the phos, because we can give the patient a K-phos when they have the potassium and the phos at low levels. Some of the causes of morbidity and mortality in DKA, primarily is shock, because this patient comes in a full-blown hypovolemic shock if they wait for a very long time before they come into the hospital. They can also have severe hypokalemia during treatment. That's why it's very important to replace that potassium if they're hypokalemic before you start the insulin. Hypoglycemia during treatment, talked about that. Any kind of cerebral edema during treatment, depending on what IV fluid we're using. Then they go to hypophosphatemia. That's why it's important that we're checking these electrolytes so we can replace anything that needs to be replaced. And then acute renal failure because of the hypovolemia, adult respiratory distress syndrome, ARDS, that can be because secondary to an infection. We know that patients, when they have an infection, they can go into DKA. So maybe somebody with pneumonia that will turn into ARDS, vascular thrombosis, any kind of precipitating illness, even MI, stroke, sepsis, pancreatitis, and pneumonia. DKA management pitfalls. If we're not assessing or treating the underlying cause of DKA, remember, the patient got DKA because something happened to them. And we said the number one cause is infection. So we got to make sure that we treat the cause. Or if we're not watching that potassium closely enough and we're not replacing, that can cause a pitfall. We got to make sure that we're checking serum ketone concentrations as well. We got to make sure that we're checking the anion gap and making sure that our anion gap is not widening rather than closing. We want it to close. And interruption of IV insulin too many times. Patient may not be eating at times, and like I said, the anion gap is still not closed. some more pitfalls, occurrence of rebound ketosis, consequent to the inadequate insulin infusion transition, or if they don't give long-acting insulin, inappropriate extension of hospitalizations, and sometimes patients just don't understand. That's why we want to make sure that we educate, but before we educate, we want to make sure they have a readiness to learn. And then, of course, inadequate follow-up can also occur with some of these patients. Okay, so now we're headed down to finding the cause and preventing recurrence, because this is really our goal as we take care of these patients, that we want to make sure that they understand what caused the issue to begin with, and we give them education to prevent this from happening in the future. So some of the possible precipitating factors, I did talk a lot about infection as one of the causes of DKA for their type 1. There is some non-adherence to their regimen. Sometimes what happens is if someone has a psychiatric issue, they may tend to forget to take their medication, or they're dealing with other things in their life that their health unfortunately will come secondary. Another thing can be that there's errors in how they understand on how to manage their insulin therapy. Sometimes a lot of these type 1s, especially when they start very young, do have these insulin pumps that you guys hopefully learned back in 121L. But sometimes they'll have malfunctions to these pumps, and they may not understand themselves because either they didn't get the proper training to begin with, or they're just thinking that their pump is working, because it normally does work. It's rare that we have malfunctions, but it does happen. Another thing can be a sick day management. They're not able to manage their sick days properly. Infection, like I said, is primarily the main reason. Sometimes MI due to the physical stress of the body. Pancreatitis, a lot of the pancreatitis, which you guys will learn later in the term, but pancreatitis primarily begins from gallbladder issues. Yeah, that gallbladder will be inflamed and will cause pancreatitis. By rare cases, endocrinopathy, sometimes along. Another one is steroid therapy. As hopefully you remember that with steroids increase our blood glucose levels in our body. So steroid therapy can be a reason for them to get DKA for our type 1s. For our types 2, a lot of it is kind of like the same of what we talked about with type 1s. Sometimes the only thing is with our type 2s, we know that they'll have renal insufficiency, which will be a secondary problem to their diabetes. And otherwise, everything else is the same. The only difference is the renal insufficiency. So as we get ready to discharge these patients, we like to provide them with some diet information. We also do a lot of teaching with glucose monitoring. We want to teach them to keep a log, that way they can see trends with their blood glucose. Other things that we do is talk to them about treatment goals and where they should stand as far as their glucose levels, any kind of contact numbers that they need, if they need to contact anyone if they have further questions. They need a medical alert bracelet just in case they become hypoglycemic and are unable to speak for themselves. And teach them skills such as having like hard candies available for if they get hypoglycemic, anything that they can possibly need if in any kind of emergency. That's what we consider our survival skills training. More education on our type 1 diabetics is primarily going to all be focused on preventing DKA. Initially, we want to recognize where there could be a lack in their education, and we can start from there. And as I mentioned before, remember, before we start educating our patients, we want to make sure that they have readiness to learn. And another thing that we have to do an assessment. We have to find out what they already know, because we want to add more information to what they already know rather than going over stuff they may already know, because then you're going to bore them and they're not going to listen to you. So we want to recognize symptoms and find that required contact with their healthcare provider. We want to make sure that they understand when their kid possibly be going into any kind of DKA symptoms, and we want to make sure that they understand they need to contact their healthcare provider immediately to hopefully prevent them from going into the ketonic state, meaning that they'll go into metabolic acidosis. Self-management skills we can teach them is make sure they understand how to take their glucose, not only the scale itself, but how often, and if when they're feeling changes as far as hypo or hyperglycemic, to make sure that they check their sugar at that time. We want to make sure that they know how to, if they have the opportunity to do urine acetone testing. Some of these patients are trained on how to check their urine. They're sent home with the strips. We want to make sure they understand that. Want to make sure they understand the management of insulin on sick days. A lot of times when people are sick, they will run higher blood glucose levels, so they need to understand how to properly manage their insulin at that time. And kind of goes along with the next comment, what I just talked about. And then we want to make sure we address any social factors that they may possibly be going through, because that can also be causing additional stress. This is just a little picture for my visual learners, showing you how DKA begins, and the onset and how quickly it can happen, and some of the symptoms that we've kind of gone over with this presentation. This is another one showing you signs and symptoms. They'll have the dehydration, the abdominal pain, the acetone breath, Kussmaul's breathing, and mental changes. Okay, so now we're going to switch gears and talk about HHS, which is known as hyperglycemic hyperosmolar state. You're going to find these in your Lewis and in your ATI. Both have really good information for you to understand HHS. And a quick overview about what HHS is it's a complication that routinely happens to your older adult patients, and these are your type 2 diabetics. The breakdown of fat for cell function does not occur because insulin production is adequate. So in other words, they do not go into DKA because they have some insulin available, versus our type 1 diabetics that have no insulin available. So with these people, it occurs very slow. They can go into severe hyperglycemia, more so than your DKA. Dehydration and severe electrolyte imbalances may or may not exist, but the main thing that you need to remember is that they do not go into an acidotic state. This one here will have values as high as 600, which we know with our DKA, they can be considered DKA even as high as 250. So with your HHS, it can be as high as 600. I've seen patients come in with blood glucose almost in the thousands with HHS. Due to the insulin production, even though it is low, there is no breakdown on fat, so there's no production of ketone bodies, which the ketone bodies, the breakdown of that is what leads to acidosis. So that's non-existent in these patients. The thing with HHS is that it can lead to profound dehydration. These patients will lose 10 to 15% of body water, so very, very high levels of fluid that are lost. They'll have high hyperosmolality, which just means they have an increased concentration in the plasma, and they'll have an elevated BUN levels. HHS can be a life-threatening syndrome because of they lose all of this excess fluid, and they come in. By the time they come in, they're severely dehydrated, and the life-threatening syndrome that can occur is in patients who are they cannot compensate enough insulin to prevent DKA, but not enough to prevent hyperglycemic. So I'll repeat that again. HHS is a life-threatening syndrome that can occur in patients with diabetes who is unable to produce enough insulin to prevent DKA, but not enough to prevent hyperglycemia. They go into osmosis diuresis and extracellular fluid depletion. HHS is less common than DKA, and so that's why many of you probably will never see one of these patients or take care of these patients, and it is not that common. But when it does occur, it occurs on our patients, like I said, older patients, 60 years or older with the type 2. Common causes are urinary tract infections, pneumonia, sepsis, any kind of acute illness, and sometimes our newly diagnosed type 2 diabetics because they're unaware of all these changes our body's going through. HHS is often related to an impaired thirst sensation or functional inability to replace fluids. There's usually a history when they come in that they have inadequate fluid intake, which increases their mental depression, and they'll have polyuria. This diagram here is just showing you the differences between what they're going through, their little pathophysiology state. They'll have unchecked gluconeogenesis, which will cause them to have hyperglycemia. Then the osmotic diuresis will cause them to be severely dehydrated. Uh, Sometimes this can present with patients that have renal failure, and I talked about they don't have acidosis, and can be identified after an infection or an MI. Same like with your patient with DKA as well. As some of the differences between this HHS, their neural status is more severe than your DKA. GI, usually no GI changes. It can be normal with no GI changes compared to your DKA. That one has nausea, vomiting, abdominal pain. Their skin temperature, these patients are warm, dry, and flushed. Cardiovascular, they'll have tachycardia. And respiratory, they'll be tachypnic, but they're not going to have the acetone breath, and their urine output is increased. And this is a little bit of what I just talked about right now, and I talked about some of the symptoms that they'll have. So they'll have that severe osmosis diuresis. That's why they're peeing out so much. They have a severe fluid volume deficit. Their electrolytes are going to be down, sodium, potassium, and phos. They're going to have a profound dehydration, hypovolemia, and a lot of times with the hypovolemia, they'll have that decreased renal perfusion, hypotension, and hemoconcentration. So if you look at that, so a lot of these patients, what will happen is they'll go into seizures, shock, coma, and death. So it is just still very severe. And the problem with these patients is when they come in, they have just enormous high levels of hyperglycemia. Like I said, I've seen people in their tooth in the thousands. Highest I've seen, I think I saw one time, I saw up to 1,200. And then here's a little bit more on HHS. The main difference, as I talked about, is that the HHS will usually have enough circulating insulin to prevent ketoacidosis. HHS will produce fewer symptoms in the earlier stages. So that's why blood glucose levels will climb so high, because the problem is not recognized early. The higher blood glucose levels, they increase serum osmolality and produce more severe neurologic manifestations. There'll be somnolent, coma, seizures. Sometimes they come in, they will be mistaken for stroke. But once they run tests, they'll find that their sugars are incredibly high, and they'll change their treatment interventions. But many times, as I say, they'll come in resembling a stroke, and stroke is always a priority, so they'll start doing interventions for stroke, and then, like I said, find out that they'll have this critical glucose levels. They'll be greater than 600, and if they do have ketones at all, it's going to be very minor, so nowhere near like your DKA patient. It is considered a medical emergency because it does have a high mortality rate, because our elderly patients do not have any reserves, so they cannot compensate as quickly as someone that is younger. The management of DKA and HHS are similar, and as far as it, we're going to start giving them a lot of IV fluid. We'll give them boluses of fluid. Primarily, it's normal saline. And as mentioned with DKA, at one point they will switch to half, but initially it's going to be normal saline. We're going to start rapid infusions of isotonic fluid, which is your normal saline, because we want to start giving enough perfusion to the vital organs. We don't want our organs to start shutting down. They do have some cardiac or renal compromise, so we want to make sure that as we do replace fluids, we're keeping that in mind as well. When blood glucose levels reach about 250, IV fluids containing glucose are administered to prevent hypoglycemia. Electrolytes are monitored and replaced, and hypokalemia is not as significant in HHS as it would in DKA, although fluid losses may result in milder potassium deficits that will necessitate replacement. One thing that I did want to add, and I didn't tell you with the previous slide, is that when you have a patient with HHS, you want to make sure that you're assessing your vital signs, that you're keeping a very close eye on your intake and output, and it's being done strict INOs. You're going to be checking skin turgor, and keep in mind that with skin turgor for your elderly patients may not be as adequate as someone that's 20. Lab values, you're going to keep a close eye on that. And when we talk about lab values, these are some of the changes that you'll see. With your HHS patient, we know that the glucose is going to be very high. It's greater, sometimes greater than 600. Sodium is going to be high. Your potassium is going to be low because you're peeing it out. Your hematocrit is going to be high because you're severely dehydrated, which is another reason why your sodium is high, because you're severely dehydrated. Think about a cup of water and you add 2 teaspoons of salt and you mix it together. The salt is going to be very concentrated because there's less volume. Now think about another cup. You feel it, it's twice the size, and you add the same amount of teaspoons of salt and you mix it together. The salt levels are going to be lower, not because there's less in the body, but because there's more volume to dilute it. So if you think about it that way, it'll be a good way of helping you remember. Hematocrit high, same reason, because patient is severely dehydrated. Serum osmolality is high as well because there's more particles in the blood because there's less volume. Your pH is normal. Bicarb is normal. PaCO2 is normal. BUN and creatinine is elevated because our kidneys have taken a hit because we are severely dehydrated and we've lost so much volume. Your serum ketones is going to be normal, and your urine ketones is going to be normal. One of the things we want to do when these patients come in is we want to find out what is a precipitating cause, because we want to make sure we address that. Addressing that issue will prevent them from having further complications. But we usually stabilize the patient first. That's priority. They're severely dehydrated. We're going to give them a lot of volume. We're going to stabilize them, and then we're going to go ahead and try to find out what has caused them to go into this HHS state. Now with this slide, compared to DKA, HHS, there is greater severity. That's why if you ever have these patients on your unit, your HHS patient should be one that you see first. Part of the reason is because, number one, they're elderly, so they don't have the same sensation that you and I would to know when they're physically having harm to their body. For example, their thirst mechanism has now decreased. They cannot sense a dehydration as much as you and I can because their thirst mechanism is decreased. So this is a patient that they can go out on a hot day and not realize that they're dehydrated because their thirst mechanism is down. So they're unable to recognize that. They're going to be severely hyperglycemic, greater than 600. Hypernatremia is present because, like I mentioned earlier, there is not enough volume to dilute this salt in the body. Then they're going to have the hyperosmolality as well because there's more particles in the blood because they're not able to dilute these particles. When you think about osmolality, like osmolality in urine or osmolality in blood, think of it less particles, okay? Like there's more particles in it or there's less particles in it, and bring that together with fluids, mixing some kind of particle in water. If you have more volume, there's going to be less particles. If you have less volume, more particles, more volume, it's going to be less particles because they're diluted. Some of this insulin typically persists because they do have that insulin. They will persist in HHS states, and because it's a slow process. Ketosis is absent to minimal and is insufficient to produce significant acidosis. That's why acidosis is something rare in our HHS population. Now, your patient profile, as mentioned, these guys are going to be elderly. They are going to be usually greater than 60. They're going to have more comorbidities, which is a reason why they don't do as well, because they don't have any reserves to recover because they have other presenting problems. They have a history of type 2 diabetes, which may have been recognized, so they're having these symptoms, but they're not able to realize that they're presenting with diabetes symptoms. It's more insidious development, meaning by it takes longer. Remember, with DKA can happen as quickly as a few hours versus your HHS takes longer. Greater osmolality and mental changes. That's why when they come in, we think they have a stroke. Dehydration presents with a shock-like state. They're in hypovolemic shock when they come in. That's why we start treating them with fluids, and we have to make sure that we're providing, along with providing sufficient fluid, we're also checking to make sure that we don't overload them, because we want to deal with one problem at a time. We don't want to create more problems. However, it's always easier to correct overload than to not give enough and keep them dehydrated. Now, as with this slide, some of the treatment interventions we're going to do is we're going to monitor IV fluids. With some of our HHS patients, once we give them fluid, many times we don't even have to start them on insulin drip therapy. So with them, we're going to closely monitor blood glucose and urine output. We will check for ketones, and we're able to determine this pretty early once they come into our care. We're going to monitor IV fluids to correct dehydration, insulin therapy to decrease our blood glucose, and any kind of serum acetone levels. Remember, I'm talking about both. I'm talking about DKA and HHS. Electrolytes are given to correct electrolyte imbalance. We are going to assess renal status. We're going to check cardiopulmonary status for both, because remember, our elderly are now on a higher risk for fluid volume overload. Electrolyte levels, we're going to monitor ALOC, check our potassium imbalances, replace any kind of therapy that they need, whether it be magnesium. All the electrolytes are going to be replaced. Assess for signs of osmotic diuresis. With treatment with insulin begins, serum potassium levels will decrease rapidly. That's why we want to make sure with our HHS patient that will present with low potassium levels that we replace that before we give insulin. Because what can happen is if we don't replace that potassium and we start the insulin, remember insulin is going to carry the potassium into the cell as well. So we don't want to create a severe hypokalemic state because then we don't want them to have dysrhythmias. These patients are going to be on monitors because they can have hyperkalemia or hypokalemia. So we want to make sure that they're on a cardiac monitor. We're going to monitor for signs of fever, hypovolemic shock, tachycardia, and any kind of Kussmaul's respiration. Now switching gears, now we're just talking about HHS. I hope that previous slide doesn't confuse you, but try not to get confused. Now, the way we treat fluids in HHS, they're going to require more free water and greater volume replacement than your DKA patient. Remember, they come in severely dehydrated. However, we are still going to avoid heart failure. That's why we keep a very vigilant eye on how much fluid we're giving, especially an elderly that already has pre-existing heart conditions. Potassium, like mentioned before, we will replace before we start any kind of insulin therapy. This current slide gives you very valuable information because it's able to let you see the differences between your DKA patient and your HHS patient. Although some of the presenting symptoms are the same, these are some that when you're looking at lab values, this is a good slide to show you the differences. As you can see with plasma glucose levels, with DKA 250 versus your HHS is 600. Your DKA patient is going to be acidotic, so their pH is going to be less than 7.3, and your HHS patient, not necessarily, their pH is going to be greater than 7.3. Remember that I said it's normal. Your bicarb levels are going to be down for your DKA, but they're going to be normal for your HHS. Ketones, there are minimal to none in your HHS, but you will have a moderate, large amount for your DKA. And because of this, they will have that anion gap, which is greater than 12. For your HHS, it's important for you to remember that their serum osmolality will be greater than 320. That is like a key lab value that many practitioners use for treatment, so you should know that. This is another one comparing both side by side. They're going to have severe hyperglycemia, but your HHS is profound. They're going to have ketones, DKA, HHS, no ketones, and no acidosis. This one is going to develop over a few hours. HHS develops over days and weeks. DKA, more common on your type 1. Once in a great while you'll see type 2. Not typically though. Your HHS has a higher mortality rate. And I've talked about some of the reasons why it's higher mortality, because your elderly population has more comorbidities. They come in with these enormous levels of hyperglycemia. They come in severely dehydrated in hypovolemic shock. Okay. This one here is just showing you another one, what typically they're going to look like. They're going to be older, as mentioned before, rather than your DK, with your type 1s tend to be younger. I just kind of let you take a look at that because I talked a lot about this already in the presentation. Here's another side-by-side comparison versus your DKA and your HHS. And as you can see that the potassium levels, what they look like, calcium, Just a side-by-side comparison so you can see the differences in electrolytes and fluid deficits. Another one with the lab findings. Um, this was just, it showed you another one that looks just like it, but this one's just a little bit different. It's giving you normal ranges, which I like to give you normal ranges as well. But you can see the same graph that you saw earlier, just in a different format. This one is a protocol for HHS, and if you remember the one for DKA, they tend to be just a little bit different because we do treat them a little bit differently with them. And as mentioned before, there's times that our physicians may not even do IV insulin. They'll sometimes even just go with sub-Q because when we start replacing their volume, we're able to bring down their sugars without even requiring a insulin protocol that's IV related. And I'm not going to go too much into this. I just want you to see what they look like because every hospital has their own protocol, so I don't want you to get caught up with how we manage this. They're very, and in fact, most nurses, when they get patients that either have DKA or HHS, will print out their insulin protocol because none of us have this memorized, and we don't have it memorized because it depends on where you work, how you're going to manage them, and there's different scales as well. So no sense in memorizing different scales when your physician may order a different kind of scale. We have aggressive versus non-aggressive, DKA versus HHS. So many times, and I know for myself, I'll print up my protocol and follow it based on my blood glucose levels. All you need to know is that protocols exist, and we base how much insulin we give our patients depending on their blood glucose levels. So when we're transitioning from IV insulin to sub-Q, these are some of the things that we do and some of the parameters we're looking for. The anion gap has to be closed for your DKA before we start sub-Q insulin. With your HHS, once their osmolality starts normalizing and they're able to regain their mental status, we can switch them. That's why, like I mentioned, a lot of times just from providing all this fluid, we don't even need to start the IV insulin. We'll go straight to sub-Q. We'll allow an overlap of 1 to 2 hours between sub-Q and the discontinuation of IV insulin. If we do initiate IV insulin, we will have that overlap in time. So in summary, DKA and HHS are both life-threatening emergencies. That's why we discuss them in this course, because we do advanced interventions for these patients. And it's important that we not only initially treat the patient when they come in for their emergencies, but we want to find out what was the precipitating cause. We want to make sure we're managing their fluid and electrolytes because that's going to be very important. And another thing that we want to do is we want to make sure that we're starting their insulin therapy as ordered. We understand the different types of insulin therapy. We're going to do vigilant patient monitoring. They're going to be on a cardiac monitor because of their electrolyte imbalance. We're going to prevent metabolic complications during recovery, and we're going to transition them to long-term therapy. Sometimes for your DKAs, we'll start NPH, long-acting insulin, and slowly transition them back into whatever intervention they were using at home. So here are some tips for you to remember with these patients. First tip is you need a way to remember the differences between the potassium changes in DKA and HHS. Just begin with the concept that metabolic acidosis is trying to compensate the exchange of hydrogen for potassium ions. That's why they result in hyperkalemia in DKA. HHS is all about diuresing. They're peeing it out. They're losing the potassium. There's lots of P in potassium Remember, there is a small amount of insulin available, so there will be no breakdown of fat, which will produce ketone bodies, which will prevent the development of acidosis. HHS leads to profound dehydration. Both DKA and HHS, the priority is to hydrate rapid amounts of isotonic fluid to maintain perfusion to vital organs. Regular insulin needs to be administered IV. Do not decrease blood glucose faster than 100 milligrams per hour uh, because the body will go into a hypoglycemic state. So we have to make sure that when we are, that's why we have these strict insulin monitoring scales, because we don't want to cause rapid changes from our blood glucose levels. Cannot be faster than 100. Monitor glucose levels every hour. This is why these patients are in critical care, because we have to check their sugar every hour. Only in DKA, we're going to monitor for hyperkalemia due to acidosis. Monitor the pH for severe acidosis. Only in HHS, you're going to monitor for hypokalemia from diuresing. Monitor urine output to make sure they're going to be safe. Remembering, when starting IV potassium supplement, it must be diluted and administered slowly. You should never give no more than 10 MEq of potassium if it's an IV. Never administer potassium IV push or bolus. Remember, we are not in practice of killing patients. If you bolus potassium, you can kill a patient. I hope this is helping you remember the difference between both of them. I personally really enjoy the endocrine system. These diseases are things that I really enjoy and I understand really well. So I hope that I can pass this on to you and that you'll remember the differences between your DKA and HHS. Now we're going to switch gears into hypoglycemia. And I have included hypoglycemia in this presentation because with all the treatments that we give, our patients have a very high probability of going into hypoglycemia. So we want to make sure that we discuss it. And this will be found a very short chapter in your Lewis in 1179 to 1180. So what happens with hypoglycemia in our case when we're dealing with our DKA and HHS is that there is just too much insulin in proportion to glucose in our body. And this tends to happen when we're in these aggressive insulin protocols. So what happens is our blood glucose levels will drop to less than 70. And when our glucose drops below 70, neuroendocrine hormones are released and the autonomic nervous system is activated. This is why you're going to have increased epinephrine levels, and your patient is going to have tremors, tachycardia, irritability, impaired vision, restlessness, excessive hunger, and they're going to have diuresis. Diuresis is triggered through our adrenergic nerve endings, and it's typically grouped with the adrenergic manifestations of hypoglycemia. And these are some of the manifestations I talked about. Because of this epi release, it's going to cause all of these symptoms. They're also going to have anxiety, hunger, and they're going to have a pallor. Some of their, when you go to see these patients at the bedside, they're going to have difficulty speaking. They're going to have altered mental function. They're going to have visual disturbances, blurriness. They're going to have stupor. Stupor means that they're going to be lethargic. They can go into a coma. They can also have seizures because remember, our brain functions with glucose. So if there's decreased glucose to the brain, they're going to have decreased cognitive function. Our brain requires a constant supply of glucose, and it has to be in sufficient amounts for our brain to function. That's why it's never a good idea to try to study when you're hungry. Eat a small carbohydrate or a protein snack, and then let that digest for a few minutes, and then you can go ahead and study, because if you have no glucose in your brain, it's going to be hard to concentrate. Same with testing. You should have a light snack before your exams so you're able to concentrate. Some manifestations of hypoglycemia can mimic alcohol intoxication. Untreated hypoglycemia can progress to coma. And if you think about the word coma, C, confusion. O, orientation. So you're going to have a decreased LOC. M, for mental illness, because they're going to look like they have mentally ill. A, for apathy, meaning lethargic. And S, because they can go into seizures. So that's a good way of remembering comas. With just hypoglycemic unawareness, they're unaware initially. This person does not experience the warning signs unless they've been diabetic for a really long time. Some of them are pretty good at picking up their signs and symptoms, but others don't. Sometimes what happens, this will happen in their sleep, and the person will become incoherent, sometimes combative because they get so confused, or they may even have a loss of consciousness. This is usually referred to the autonomic neuropathy of diabetes that interferes with the secretion of the counter hormones that produce these symptoms. Patients at risk for hypoglycemic are those with repeated episodes, your older patients, patients who use beta blockers, because beta blockers make them insensitive to insulin. Using intensive treatments to get tight blood glucose control, which is what we do with our DKA and HHS. Unfortunately, when they do get these hypoglycemic states, we usually are the ones that have caused it because of our protocols. These patients are usually managed with blood glucose goals that are higher than those of patients that do not come in with either DKA or HHS. Sometimes, even if a patient's blood sugar based on a protocol will be about, let's say, 90 or 85, my protocol is still going to tell me to give insulin, which feels always really rare to do that. It feels weird, like if you're doing something out of the norm. But according to the scale, these scales have been tested and they work, but unfortunately sometimes for some people they will get hypoglycemic. Some of the causes are mismatch of the timing of food intake and the peak action of insulin or oral hypoglycemic agents. That's why it's important to have food available for your patient when you give them that their regular insulin. Remember that regular insulin can kick in really fast. The onset of some of your regular insulin can be as quick as 15 minutes, and they peak in about half hour. So that's where you want to make sure that there is a meal available for them. And your even your Humalogs that are like 75, 25, or 70 and 30, those onsets are still pretty fast, can be anywhere from 50 to 30, or your 70-30, your onset's about 30 minutes. So sometimes this hypoglycemia can occur at any time, but some of these episodes occur when the patient is sleeping, or the insulin has peaked and the patient's daily routine is disrupted for some reason or another, because of activities or sickness or medications. Although hypoglycemia is more common with insulin therapy, it can occur with oral agents. It may be severe and persist for an extended time because the longer duration of action. Hypoglycemic symptoms may occur when a very high blood glucose level falls too quickly. Sometimes we can be looking at blood glucose level of 300 falling quickly to 180. That's almost half. So that's why we want to make sure that we don't do that when we're with our insulin protocols. Although blood glucose levels is above normal by definition, like let's say the example I just gave you, the 180, it's still a quick metabolic shift, and the body does not like that flip-flop. So it, although it's still normal and actually a little higher than normal, it can evoke hypoglycemic symptoms. So that's why it's important to keep a very close eye on this. Checking blood glucose levels is important. We want to make sure that we reverse this hypoglycemic state pretty quickly. We want to make sure, remember, our brain functions with sugar, so we want to make sure that we manage this quickly. So the first, we want to make sure we know the signs of hypoglycemic, and I talked about some of those: tremors, tachycardia, irritability, restless, hunger, diaphoresis. They can go into coma, and I gave you a good way to remember coma and the symptoms that come along with comas. If blood glucose is greater than 70, investigate other possible causes. If your patient is awake enough for let's say they're arousable, and you find your patient and you notice that they're exhibiting these signs, but they're arousable, they haven't got into a coma state. One quick way to fix them is just give them some orange juice. Give them 4-ounce cup of orange juice. You'll bring them right back up. And when you do get a patient that's hypoglycemic and you do an intervention, you want to make sure that you go back and recheck their sugar in at least in 15 minutes. But the first thing you want to do is you want to give them something to bring up their blood glucose. And if they're awake enough, a cup of orange juice can do the trick. So here is a good rule to follow. Follow the rule of 15, what we call the rule of 15, to treat hypoglycemia. Any blood glucose less than 70 is treated by indigestion of some kind of simple carbohydrate, which is that 4 to 6 ounce of fruit juice or regular soft drink. We do have commercial products that are gels and tablets that contain glucose, and sometimes we, as far as our teaching goes, we encourage some of our patients to make sure that they have some kind of sugar-containing tablet, or they can even have candy to help them bring up their sugar. So you gave them the juice, you want to go check their blood sugar 15 minutes later. If their blood glucose continues to be less than 70, ingest another 15 grams of more carbohydrate. You're going to continue checking their blood sugar every 15 minutes until you see that there has been some improvement. If there's no significant improvement after you've done this 2 to 3 doses of 15 grams of a simple carbohydrate, then you want to go ahead and call your physician. Because of the potential of rebound hypoglycemia after an acute episode, have the patient ingest that complex carbohydrate after recovery to prevent another hypoglycemic attack. Avoid treatment with carbohydrates that contain fat, such as like a chocolate, like a candy bar, cookies, whole milk, or ice cream. Because what happens is the fat in these foods will actually slow down the absorption of sugar and will delay the response to this treatment that you've just been given. Avoid overtreatment with large quantities of quick-acting carbohydrates, so you don't go from a hypoglycemic state to now a hyperglycemic state. Okay. Some more treatment in acute care settings. Now your treatment is going to be a little different here, and it still depends on if your patient is alert or not. And we may treat these patients with anywhere from 20 to 50 cc's of 50% dextrose. So what you'll hear is give them an amp of D50, and an amp contains about 50 cc's. It's a very big syringe, and because it's glucose, it is very difficult to push. So make sure that you have strength, or you use your good strong hand when you're pushing this. If you're doing it IV, it's very thick and it's hard to push. You might even need two hands. Another option is if the patient's not if they're alert enough to swallow and they have no IV access, you can administer 1 milligram of glucagon IM or sub-Q. An IM injection in the deltoid is the best place to go because it'll give you a quicker response. Glucagon stimulates a strong hepatic response to convert glycogen to glucose, and therefore it makes that glucose rapidly available. Nausea is a common reaction, so you need to educate your patient that they may get nausea after a glucagon injection. To prevent aspiration or vomiting occurs, turn the patient to the side once he or she becomes alert. Once this acute hypoglycemic state has been reversed, explore the reasons what happened, because remember, we always going to address emergency first, and then we're going to do our little investigation on what caused this. We want to make sure we teach our patient, their family, on how to avoid future hypoglycemic states. This picture here is just showing you, for my visual learners, showing you how quickly it can happen and what your patient's going to present like, and they need sugar. So sugar is going to be their treatment intervention. Okay, so now we're switching gears, going into antidiuretic hormone imbalances, more on your endocrine system. We're going to talk about diabetes insipidus and syndrome of inappropriate diuretic hormone. Both of these are going to be found in your ATI and your Lewis book.